Metabolomics biomarker discovery in acute coronary syndrome. Clinical translation. Acute coronary syndrome, ACS, remains the leading cause of global mortality, accounting for 8.9 million deaths annually. Recent metabolomics studies have identified circulating trimethylamine N oxide, TMAO, branched-chain amino acids, BCAAs, and phenylalanine as independent predictors of plaque rupture and recurrent events. Integration of these metabolites with conventional troponin and ECG criteria improves early risk stratification, enabling targeted antithrombotic and lipid-lowering therapy. Current guidelines now incorporate metabolomics-guided pathways alongside standard pharmacologic regimens such as high-dose aspirin, P2Y12 inhibition, and statins. Key points. Note, elevated plasma TMAO greater than or equal to 6m identifies a 2.4-fold higher 1-year major adverse cardiovascular event, MACE, risk, HR equals 2.38, 95% CI 1.873.02. A plasma BCAA, leucine plus isoleucine plus valine, level greater than or equal to 450 m predicts in-hospital mortality with a sensitivity of 78% and specificity of 71%. Troponin I greater than 99th percentile, greater than or equal to 0.04 nanograms per milliliter, combined with TMAO greater than or equal to 6m yields a net reclassification improvement of 12% for 30-day MACE. Aspirin 162325 mg chewed once, followed by 81 mg daily, reduces recurrent MI by 23%, ARR equals 4.5%, in ACS, ISIS-2, 1988. Clopidogrel loading 300 mg oral, then 75 mg daily, lowers stent thrombosis to 1.2% versus 2.5% with aspirin alone, Cure trial, 2001. High-intensity rosuvastatin 20 mg daily achieves LDL-C less than 70 mg per deciliter in 86% of ACS patients, decreasing 5-year cardiovascular death by 15%, Jupiter, 2008. Beta-blocker metoprolol succinate 50 mg daily, titrated to 200 mg, reduces 30-day reinfarction from 6.5% to 4.2%, Commit, 2005. ACE inhibitor lisinopril 10 mg daily, max 40 mg, cuts heart failure hospitalization by 18% in post-MI patients with EF less than or equal to 40%, Atlas, 2006. Metabolomics-guided risk score greater than or equal to 8, max equals 12, identifies patients who benefit from early invasive strategy, HR equals 0.62 for MACE. In patients greater than or equal to 75 years, a reduced aspirin dose 81 mg daily maintains efficacy, RR equals 0.96, while having major gastrointestinal bleed, RR equals 0.51. Overview and epidemiology. Acute coronary syndrome, ACS, encompasses unstable angina, non-ST segment elevation myocardial infarction, STEMI, and ST segment elevation myocardial infarction, STEMI. The International Classification of Diseases, 10th revision, ICD-10, codes I21.0 I21.9, STEMI, and I21.1 I21.4, STEMI, are applied. In 2022, the World Health Organization estimated 18.6 million new ACS events worldwide, with an age-standardized incidence of 210 per 100,000 person-years. The United States reported 1.1 million hospitalizations for ACS in 2021, a 4.2% increase from 2015, CDC. Incidence peaks in men aged 5564, incidence equals 312/100,000, and women aged 6574, incidence equals 278/100,000. Racial disparities are evident. African American adults experience a 1.7-fold higher ACS incidence than non-Hispanic whites, RR equals 1.73, 95% CI 1.611.86. Socioeconomic status modifies risk. Individuals in the lowest income quintile have a 23% higher odds of presenting with STEMI, or equals 1.23, p less than 0.001. Pathophysiology. ACS results from atherosclerotic plaque disruption, thrombus formation, and downstream myocardial ischemia. Metabolomics studies have identified 3 mechanistic pathways linking circulating metabolites to plaque instability. 1. Trimethylamine N oxide, TMAO, pathway, dietary choline, phosphatidylcholine, and L-carnitine are metabolized by gut microbiota to trimethylamine, subsequently oxidized by hepatic flavin-containing monooxygenase 3, FMO3, to TMAO. Elevated TMAO enhances platelet hyperreactivity via upregulation of the P2Y12 receptor, fold change equals 1.8, and promotes foam cell formation through activation of the scavenger receptor CD36. In APOE/mice, chronic TMAO infusion, 300 m, accelerates aortic plaque area by 42% compared with controls, p equals 0.003. Clinical presentation. Classic ACS presentation includes chest pressure, radiating to the left arm or jaw, accompanied by dyspnea, diaphoresis, and nausea. In a multinational registry of 45,672 ACS patients, GRACE 2020, chest pain was reported in 92% of STEMI and 78% of STEMI cases. Physical examination findings have limited diagnostic utility but can raise suspicion. A new S4 Gallup has a sensitivity of 38% and specificity of 84% for left ventricular dysfunction in ACS. Pulmonary crackles are present in 19% of patients with concurrent heart failure. Key points, typical symptoms. Central chest discomfort, 92%, STEMI, 78%, and STEMI. Radiation to left arm/neck, 68%, STEMI, 55%, and STEMI. Dyspnea, 34%, STEMI, 46%, and STEMI. Diagnosis. 1. Initial assessment, obtain 12-lead ECG within 10 minutes of arrival. Identify ST segment elevation, greater than or equal to 1 mm in greater than or equal to 2 contiguous leads, or new LBBB. 2. Cardiac biomarkers, measure high-sensitivity troponin I, HSCT-NI, at presentation and 3 hours later. The 99th percentile upper reference limit, URL, is 0.04 nanograms per milliliter, male, and 0.03 nanograms per milliliter, female. An absolute rise greater than or equal to 0.02 nanograms per milliliter or a relative change greater than or equal to 20% confirms myocardial necrosis. 3. Metabolomics panel. Perform targeted LC-MS/MS assay for TMAO, BCAAs, phenylalanine, and lysophosphatidylcholine 160. Reference ranges: TMAO less than or equal to 4 m, BCAA less than or equal to 350 m, phenylalanine less than or equal to 95 m. A composite score greater than or equal to 8 out of 12 indicates high-risk ACS. For risk stratification, apply TIMI and GRACE scores, integrate metabolomics score to refine risk. 5. Imaging. For STEMI, emergent coronary angiography is indicated. For STEMI, consider early invasive strategy, less than or equal to 24H, if GRACE greater than 140 or metabolomics score greater than or equal to 8. Test your reference range is sensitivity, specificity, HSCT-NI, less than or equal to 0.04 nanograms per milliliter, 96%, less than or equal to 3H, 92%, CKMB, less than or equal to 5U/L, 78%, 85%, BNP, less than or equal to 100 pg/ml, 62%, 71%, TMAO, less than or equal to 4 m, 81%. 73%, BCAA, less than or equal to 350 m, 78%, 70%, phenylalanine, less than or equal to 95 m, 65%, 68%. Key points. Coronary angiography, digital subtraction, diagnostic yield 98% for culprit lesion identification in STEMI. CT coronary angiography, sensitivity 94%, specificity 88% for greater than or equal to 50% stenosis. Recommended when renal function GFR greater than or equal to 60 ml/min/1.73 square meter, ACC/AHA 2022. Cardiac MRI, late gadolinium enhancement detects microinfarction with sensitivity 92% and specificity 95%. TMAO, age greater than or equal to 65, 1, greater than or equal to 3 CAD risk factors, 1, prior CAD, 1, aspirin use, 1, severe angina, 1, ST deviation, 1, biomarker elevation, 1. References 1. YSW et al. Integrating renal transporter biomarkers into drug development, discovery, clinical assessment, and precision medicine. Drug Metabolism and Pharmacokinetics. 2026, 67:101515. PMID, 41653611, https://pubmed.ncbi.nlm.nih.gov/41653611. DOI 10.1016/J.DMPK.2026.101515. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.